start straight away with a case study just to sort of give you a highlight of the type of patient that we see in our endocrine DMD clinic. So um, this patient now is 20 and obviously has DMD. He is on your sort of fairly standard steroid dose. He's on 20 milligrams a day and has been on since he was 5. He's also on vitamin D, and as we used to do in Newcastle routinely as part of our sort of standard of care a long time back, he's actually been on oral bisphosphonate since he was around 6 years of age. He came into our clinic when he was 13 because he didn't show any signs of puberty. And at that point, we started him on a 2-year regimen of gradually increasing doses of testosterone via injection every 4 weeks. Unfortunately, as we see with a lot of our young men with Duchenne, he then had a difficult couple of years, which led him to becoming non-ambulant. So when he was 13, very simply knocked his leg against the side of a chair in the classroom and developed an undisplaced fracture of his leg. He then fell just after he got back on his feet again, 6 months later when he was going to the toilet, and sustained a left distal femoral fracture. So alongside his testosterone treatment, we then were considering adding in an IV bisphosphonate as well. He then came to us just as we were discussing that with him with some more severe back pain. And so we went on to do some spinal imaging, some x-rays. And you can see here from the right-hand image there that he's got some wedging of his vertebrae at the bottom of his thoracic spine. So we moved him on to some IV bisphosphonate infusions. He also had a bone age x-ray at this time, and this showed that at the age of 17 and a half, his bone age was only 11. And hopefully you can see there on the hand x-ray on the left-hand side there, there's lots of sort of lines just at the distal end near his hand of his arm bones, and those are Harris arrest lines from the bisphosphonate infusion. And what I wanted to sort of highlight here for you is the amount of different problems that these teenagers have during their adolescent years, but also how they're quite unusual compared to other patients we see in that their bone age is a long way behind, so they're still growing. And that makes this patient group really unique and really challenging when we're thinking about them in our clinic. So moving forward to the sort of the main focus of this presentation, pubertal delay in Duchenne. So unfortunately, pubertal delay is almost universal in those who are treated with daily glucocorticoids. And my colleagues in Glasgow have just published a very nice paper highlighting the frequency of delayed puberty. And basically, they showed that almost all patients who are on daily steroids have delayed puberty or don't go into puberty at all without help. And even those on intermittent regimens have a very high chance of having delayed puberty as well. We know as well that pubertal timing is crucial for bone health, and hopefully in that case study I just showed you, it's really, really important. So up to half of boys with Duchenne go off their feet if they have a long bone fracture. And you can see, as in our patient, he was just at that age where you tend to lose ambulation anyway, 13, and then had these fractures of his legs and never really got back onto his feet. But we also know that up to half of your bone density is actually accrued at puberty. So you can see from this circle here, this rapid increase in bone mass that happens during normal puberty. So obviously here, the key thing is that we don't want these boys, these teenagers, to miss out on this opportunity because it's so crucial to keep them on their feet for as long as we can. There's also the really important aspect here, which is the psychological impact of delayed puberty. And I'll talk a little bit more about that later, but clearly it's really important that these young men don't miss out on, feeling like, looking like, and being like their peers. So just a very quick reminder here, I don't expect you to need to know the biology in great detail, but I just wanted to highlight the importance really of testosterone, growth hormone, and IGF-1, which is another growth factor, on both muscle and bone. So when the higher levels in the brain signal the start of puberty, the anterior pituitary, which is that little pea-sized gland just sort of in the middle of the brain, straight behind your nose, that sends out hormones called luteinizing hormone and follicle stimulating hormone, so LH and FSH. And these stimulate the testes to produce testosterone. That testosterone is either then converted into estrogen or it acts directly on the growth plate. And it has several effects in the growth plate. It causes osteoblast proliferation, so those are the bone building cells in our bones, but it also acts directly at the level of the cells in the bone to produce both growth hormone and IGF-1, another growth factor. And these in turn also stimulate the bone. It also acts directly on muscle to cause muscle growth or muscle hypertrophy, and also increase the contractile force of muscles. And you'll all see this with your friends and family around you, that boys going through puberty become much bigger and stronger. The estrogen that's produced as a direct result of this testosterone also causes more growth hormone to be released, and that in turn acts both on muscle and bone as well. The growth hormone then signals the liver to produce extra of this additional growth hormone and IGF-1 as well, and that further acts on both the muscle and the bone. So you can see here that this sort of complex interplay between testosterone, growth hormone, and IGF-1. So it's important that we don't just think of puberty as being related to merely testosterone. We all know, and the talks yesterday and today have highlighted this, that glucocorticoids are, vital. They're really the only proven standard of care for everybody with Duchenne at the moment to stabilise muscle function. But unfortunately, what they do is that they act on the hypothalamic pituitary gonadal axis, and they prevent the release of this testosterone, IGF-1, and growth hormone at lots of different levels. And that has a direct impact on puberty. So just to remind you as well, we've just mentioned that testosterone is so important for bone density, for increasing lean muscle mass and strength, but it also increases red cell production. It accelerates linear growth. You all know of boys who shoot up during puberty, but it promotes the virilization and development of male sex characteristics as well. So all these key facts that we don't want these men to miss out on. The current standards of care aren't really that current anymore. They were developed in 2018, and they're fairly straightforward. They basically say that delayed puberty, by the time you're 14 or older, you should be referred to the endocrinologist, and we should consider treatment. What it doesn't really say is anything more than that. When should we refer these patients, and what should we do afterwards? So as part of the plan to modernise these standards of care, we've got a group called Optimise DMD, and the idea of that is that it's an international consortium to drive forward research and clinical care, particularly in the endocrine aspects of DMD. And I'm a member of the Growth and Puberty Working Group and also the Sexuality and Fertility Group, which you'll hear more from Nora, who's one of the co-chairs of that after this. But what we've done is we've really, focused in on what's missing from those standards of care. What do we need to ensure that all these boys are, getting the appropriate and correct treatment for delayed puberty? And as part of that, we sent out a survey recently to 45 members of the consortium, and we had 37 replies back to that. And as you would expect, given the makeup of the actual consortium, the majority of those respondents were from the USA, but we also had a quarter from Canada, a quarter from across Europe, mainly Italy, and also a small percentage of respondents from the UK. And because this consortium is predominantly an endocrine-based consortium, as you would expect, just over 2/3 of the replies were from endocrinologists, so hormone specialists. So I'm going to focus on those now in the next couple of slides, and I'm going to show you some of the replies to the survey. So to start with, you asked a very simple question. Do you offer pubertal induction with testosterone? And interestingly, despite the standards of care now being 7 years old, there are still, patients who attend certain centres across the world who don't get offered pubertal induction. And we think that's really, really important to look at in more detail about why, because it is so important. Then we asked what age, if you do you typically offer testosterone? And you can see here that the majority offer it when boys have what we classify as delayed puberty. So they have to have been delayed before they get offered that testosterone, whereas there's a move in some centres to offer this a little bit earlier to try and mimic the natural process of puberty, because we expect half of 12-year-olds to be in puberty. We then asked what route of testosterone do you typically use, and you can see here that the majority use an intramuscular 4-weekly, gradually increasing regimen. But there's also some use of subcutaneous testosterone and also some topical gel. And I think that's probably used mainly in the cases who are needle phobic, who can't tolerate injections. So it's fairly standardized in that it's normally by injection and either by the subcutaneous or intramuscular route. But from our survey, as I say, I haven't gone through the whole survey, that was just a little sort of snapshot of it for you. There were lots of unanswered questions, and some of those, such as what age should pubertal induction commence? If we don't commence it till 14, are we leaving it too late for, the vital effects that it has, particularly on bone, and trying to keep these boys ambulant for as long as possible? What regimen's best? What route, and how quickly should we go up on the dose, and how long should we take? Do we know what the additional effects of testosterone are on bone, muscle, heart, lungs? And what should happen afterwards? Do we know that these young men maintain their testosterone levels once we stop the testosterone? Should we be regularly reviewing testosterone levels? Are there other things that we need to take into account? And also, one of the key points that came out of the survey was, should we be offering routine psychological support to this cohort? So I just had a look at some of the studies that were available to try and answer these questions, and I'm just going to very briefly highlight these studies to you. There's only really a handful of studies. There was one done by Margaret Zacharin's group in Australia, and that was a retrospective small study of 16 patients. And they used oral testosterone initially and then moved on to a longer acting injection. And what they found was that bone density increased, and that in 10 out of the 14 who had vertebral fractures at the start of the period that they looked at, 10 of those had no further progression during that period. They didn't see a change in the body composition, but they did see an improvement in the motor function in those who were already non-ambulatory. In another group, in Janet Crane's group in Baltimore in the US, they did a sort of a mixed study, which again was a retrospective, so looking back at participants who'd been treated. And this was a mixed study of Duchenne or severe Becker, and there were 27 patients in this group, and they were looking at growth hormone and testosterone. So what they found was that they found pubertal delay in 86%. So, nearly 90% of the 27 patients had pubertal delay. And of those, 72% had been offered testosterone. And what they found was, again, as we tend to see in our cohorts in the UK, that 11 of these patients experienced vertebral fractures during the follow-up. But what they interestingly noted was that growth hormone and testosterone each reduced the risk of these vertebral fractures, either separately or in combination with a bisphosphonate. So again, suggesting that testosterone has this key role in bone protection. There was then our study that we carried out, which was a controlled prospective, so looking forward and trying to give all the participants the same regimen of testosterone and then looking to see what happened. And we took 15 patients and followed them up for 2 years originally and gave them a gradually increasing dose of testosterone every 4 weeks. And we've then looked at them a further 3 years after their last testosterone dose. And what we found was that their bone density was stable during the testosterone treatment, which is unlike the natural history data, but that it did drop a little during the extended follow-up. So in the 5 years in total, their bone density did drop. And I'll show you the results in a minute, but what we found was that there was a significant increase in the muscle contractile cross-sectional area, that the fat mass stabilized, and that instead of the decrease in the performance of the upper limb, so the motor function of the upper limb, instead of that deteriorating as we would expect to see in the natural history studies, it remained unchanged over the course of the study. So this was just a little bit more of the data from our study. And you can see here on the left side that the quality of life score in the majority of the participants increased during the 2 years of treatment, despite the fact that this is normally, the decline phase where participants become non-ambulant and more reliant on carers. We actually found an increase in quality of life. We did some qualitative work at the same time as this, and we found that the key themes really to come out of that was these young men have great concerns about how they look, and associated with that low self-esteem, and height was one of the big factors for these young men, particularly those who were still on their feet where the height was more obvious. They wanted to be like their peers, but they had difficulty sometimes in communicating this both with their family, with friends, and with their clinicians. But alongside that, and making it more difficult, was that they trust their healthcare providers implicitly to do the right thing. So perhaps sometimes, they're not really able to say exactly what they're wanting out of the pubertal induction process, and about growing up and how they want to best handle transition, for example, as we just heard Roz talking about. We found in our study, as you would expect, that giving testosterone for 2 years increased the testosterone levels, and you can see the graph on the left here. The blue line across the columns shows the adult testosterone level, and by the end of the 2 years, the mean was above this line. But hopefully you can see here as well that even 3 months after the last dose and 6 to 9 months after the last dose, the average testosterone still remained within a normal adult level. And what you can see on the right-hand side here, it's a little bit of a busy graph and I apologise for that, but if you just look at the two columns on the far right-hand side, the LH and the FSH 6 to 9 months after, what this shows is that the pituitary gonadal axis is effectively woken up. So once those injections had stopped after 2 years, they've kick-started the boys into producing their own pituitary hormones to signal their own testosterone production. And that's really important. Probably the most exciting part of the study for us, though, was that we found this increase in the muscle cross-sectional area. So from muscle MRI, we found that you can see here, both in the pink and the purple, that's the cross-sectional area, and then the contractile, so the really healthy muscle, so that we know that this isn't just fatty muscle, as you do sometimes see. So the purple bar graph there shows a significant increase in the muscle after 2 years of testosterone, suggesting that not only does testosterone have an impact on, bone health and all sort of the typical effects of puberty that you would see, but perhaps also there's this important effect on muscle as well. So just to summarize our study, we found that the testosterone injections were well tolerated, that they promoted the body itself to go into action and produce its own testosterone. During the 2 years, there wasn't a deterioration in the bones, and it improved contractile muscle bulk. So as I said, it suggests a beneficial impact of testosterone on the underlying disease process as well. And this has been sort of, just highlighted very recently. Just last month, there was a review article in the Journal of Pediatric Endocrine and Metabolism, and this was by Eugenio Mercuri's group. And basically, just to conclude, it said that, our review offers a comprehensive overview and suggests that testosterone therapy should be considered as part of the multidisciplinary management of DMD patients. And what they advised was that we need standardized protocols and common guidelines. So I think that's where we're at really in the standards of care. We know we need pubertal induction, but how best to do it? Well, that's what we really need to work towards the next standards of care showing. But one of the key things for me in this group, I've been treating these boys for a long time now, is the difficulty in bringing this up in conversation, but also how to assess and treat these young men. It's really difficult, I find, because one of the key things to assessment is the pubertal assessment, the examination. This often, by the time they've been referred, needs to be done at the sort of first visit. It's daunting, it's embarrassing, and especially with the associated neurodiversity that you often find in this patient group, it can be very, very challenging. And there's limited time to build the rapport up. So we've just created a video, which I hope you don't mind, I'm just going to show you, because I think hopefully if we can get the message out there in advance of this first meeting with the endocrine doctors, then hopefully it can be a little bit less embarrassing for them. So hopefully this will be able to play.
Steroids are really important for your muscles when you have Duchenne muscular dystrophy. But unfortunately, they can stop or delay puberty from happening. Puberty is the process when your brain tells your testes to make testosterone and your body develops into an adult. Testosterone is needed for growth of the penis and testes, development of pubic, underarm, and facial hair, deepening of the voice, confidence and self-esteem, development of stronger bones and muscles, an increase in the number of red blood cells to help carry oxygen around your body, and growth spurts. Most boys who are on daily steroids will not go into puberty by themselves. This is because the steroids stop the messages from your brain, which tells your balls to make testosterone. The easiest way to tell whether your body is making its own testosterone is by looking at and measuring the size of your balls. This might be done by your muscle team doctor, but usually it is done by another doctor who specializes in hormones, known as an endocrinologist. This may seem scary or embarrassing, but remember, the actual examination only takes about 10 seconds. The best way to check the size of your balls is by comparing them to some beads on a string called an orchidometer. It can be tricky to get into the right position to do this check, so you may want some help from a family member or one of the nurses in clinic. The doctors may also want to do some simple blood tests and sometimes an X-ray of your hand, which can tell us how much growing your bones have left to do. If there are no signs of puberty by around 12 to 13 years of age, your doctor will usually suggest testosterone treatment. This is given by monthly injection or sometimes daily gel over 2 to 3 years. The aim is to gradually increase your testosterone levels in the same way that would occur during puberty. This treatment will lead to an increase in the size of your penis, development of pubic and body hair, you'll look more grown up, and your voice will deepen. You'll probably also grow a bit, although not as much as your friends who are not on steroids. Because it is not your own body producing the testosterone, your balls will not increase while you are taking testosterone. Usually, once you stop the treatment, they will get bigger. If you have any questions, it's really important that you ask them during your appointment so you understand what's happening. Anything you want to ask will probably have been asked before by other boys. Try not to feel embarrassed. You can always talk to your doctor about things without your parents being there if you prefer. You can find out more about puberty in Duchenne muscular dystrophy by visiting the Duchenne UK website, where there are patient leaflets. This work was supported by Duchenne UK, with thanks to the young men with Duchenne muscular dystrophy who gave vital feedback during the creation of this video.
Thank you, Dr. Wood, for
Steroids
sharing. Sorry.
Oh.
Oh, I would just like to kindly ask you to wrap up during a few minutes as we have another presentation coming up. Thank you.
Yeah, sure. Yeah. So just to finish off, basically the key question, is what next after pubertal induction? And hopefully Nora, is going to go into that in more detail. So I'll just skip through this little bit here. So just to summarize, testosterone, protects the skeleton. It's important for well-being, and it may improve muscle health. But what we don't know is, what age should induction of puberty occur? Which regimen should we use? And we need shared decision making, to consider long-term supplementation after induction. The other key question that's unanswered at the moment is what will happen in the vamorolone treated cohort. And I think that's where, there are lots of unanswered questions as well. So I'd like to acknowledge all the funders and the participants in the studies that I've mentioned. So thanks very much. Any questions?